All set? Okay, welcome, and thank you for joining us tonight for the Ithaca College Occupational Therapy Alumni Speaker Series. Some of you may know me. I'm Mindy Cozzolino, the Acting Chair and Program Director for this semester. I'm covering for Dr. Julie Dorsey's sabbatical. The current president of Ithaca College, Lejeune Terry Cornish, often retorts that students are our why. Well, if students are our why, our alumni are our results. This alumni series connects our why with our results. The series ties it all together, the current work coupled with the future successes, all in one place. This alumni series is an example of what ICOT would like to foster among you all, the quest for lifelong learning and to create community wherever you may go. The speaker series was born out of vision of two amazing, almost former students, Emma Robinson and Julie Gainbard. And in their junior year, when they were digging into their OT coursework, they had realized that there were so many varied and diverse possibilities for an occupational therapist to pursue. And they wanted to learn more. So the thought for this series was born out of that idea. And they went to Dr. Jenna Heffron with their idea. And Jenna worked with them. And here we are in our third year. I'm going to turn it over now to Jenna to say a few words prior to introducing our moderators. I also want to point out that Axa Roy and Lauren Rodriguez are the new moderators, and they are taking over the helm for Emma and Julia. So this is their first time. So thank you.
Yes, thank you, Mindy. I echo your sentiments. I am very excited for this transition. Emma and Julia have also done a fabulous job behind the scenes preparing Axa and Lauren for this role. So thank you, Emma and Julia out in the virtual world here for doing that. I am thrilled to hear and excited to hear about what, Nicole, you have to share back with your ICOT family and community tonight. So without further ado, thank you all for being here, and I'll turn it on over to Axa, who is going to moderate tonight.
Okay, before I just get started with the introduction, I just wanted to draw attention to two different features of the Zoom. One of them being the Zoom closed captioning and live transcript. If you would like to partake in that, you can click on the CC live transcript at the bottom of the Zoom window next to the reactions. And there's two options for it, either option one where it shows subtitles, which will make captioning appear at the bottom of the screen. And then to turn off the closed captions, you can click on the CC live transcript again and then hide subtitle. And then also the option two, which is view full transcript, which will make live transcript appear on the side of the Zoom window. And if you want to simultaneously view the transcript and the chat feature, you can go to the top of the live transcript window and click on the downward facing caret and then pop out, and then you can move the live transcript anywhere on your screen. And then the second feature being the chat feature. The chat is at the bottom of the Zoom window next to the participants button. And similar to the live transcript, if you click on the chat button, then the caret will, at the top of the chat windows, you can choose to pop it out and move it around your screen. And we welcome you to use the chat throughout the chat feature throughout the presentation. And during the question and answer period, we'll be fielding questions from the audience through video, audio, and the chat. So just you can feel free to engage in the technology in whatever way feels best to you. Additionally, the session will be recorded along with an edited full transcript and posted to the virtual OT the virtual OT site for current students, faculty, and staff to access. So yeah. Now that that's all over, tonight is our second speaker series event of the semester of our third annual speaker series. And we have the pleasure of hearing from our alumni, Nicole Readie. She's a 2015 graduate living and working in New Jersey, and she specializes in pediatrics and serving families of children with a variety of diagnoses and neurotypes in EI and private practices. Her passions include motivating other professionals as well as caregivers to feel confident in using a strengths-based and neurodiversity affirming approach for young learners. So our speaker will start us off with an overview of their work and experiences, which will be followed by a question and answer period where the audience will have a chance to chat directly with her and ask any questions you might have. We envision this as an informal conversation and an opportunity to engage with our fabulous speaker. So without further ado, I will turn it over to you, Nicole, to get us started.
Cool, thank you. I just have to say a quick thank you to Emma, and I think Julia, what a great idea. I love this idea. Okay, so I did make a PowerPoint, but if it's pretty informal, then I can just share my screen and I can just, that's fine. Okay, so let me do that. Okay. Alrighty. View slideshow. Okay, cool. Can everyone see my screen? Thumbs up. Okay. So I believe Oxa said that there's going to be a Q&A portion at the end. So like she said, feel free to write anything in the chat in the meantime. So if you have questions and don't want to forget, sometimes I can talk really fast without realizing. So if I start doing that, like make a reaction or raise your hand or something, because that can happen. Okay. So again, we can keep this really informal, but some objectives of my presentation is to examine the role OTs play in neurodiversity affirming practice within pediatrics and how to use a coaching model to support caregivers in understanding and embracing their neurodivergent child. All right, so a little bit about me. My name is Nicole Readie. I graduated in 2015 from the OT program. I guess it was March 2015 that I was finishing up my thesis and starting field work. So kind of in the same position as some of you guys right now. I always had a passion for pediatrics. I knew I wanted to work with kids from the time I started at Ithaca to the time I finished. I actually always knew too that I wanted to probably do early intervention, but I knew that it was somewhat of like an isolating, I guess, setting where you don't work too hands-on with a lot of other professions. So I knew I wanted to wait before I did that. So right after I took my boards and everything and passed, I got my first job in a private preschool in New York City. And I was also doing some like per diem work at an inpatient acute care center for adults. I didn't really like the school setting. So I got a job at Children's Specialized Hospital, which is like a pretty well-known like outpatient clinic here in New Jersey, which was much more my vibe, seeing kids like 0 to 10 with a variety of diagnoses. But we had a really large team and I worked at 2 different sites. So I got to work with some really incredible therapists from all different backgrounds and really kind of get a nice solid foundation for my own practice. And then so my husband's from Scotland. In 2017, he decided to move back to the UK to finish school and I followed him. So I worked for 2 years in London for the NHS in community-based pediatric services, which was an amazing experience, very different in terms of like service provision than the US. It's a much more consultative model, which I think pushed me even more towards my interest in coaching. Because working at like a school and an outpatient clinic, it's very direct child service, where this was a lot of like teacher trainings, parent trainings. So that was a great experience. I moved back in 2019 and I went straight into early intervention and I'm still doing EI. Only difference now is I also do a little bit of work at a private sensory clinic nearby. And I also have a couple private clients that I see in the home. So how did I become passionate about ND affirming therapy and coaching? So during the pandemic, I was more or less laid off because I was an independent contractor. So it took a while to get the whole virtual thing going. So I was like, okay, now's my time to take like a lot of continuing ed courses. I finally, I had done my DIR floor time, like first course the year prior. And then I finally kind of had the time to do the 201. And that's when I really fell in love with more strengths-based, relationship-driven, ND affirming practice. And I think too, because of the pandemic, switching to Zoom and virtual therapy, it really was all coaching. So I saw how effective it was. I saw how confident it made caregivers. And yeah, I just kind of went from there. Since then, I've taken more fuller time courses. I've taken some courses from Learn, Play, Thrive, which is like a strength-based, autism-based organization, I guess you could say. So yeah, I currently, I book out my schedule for about 37 to 30 hours of direct child service a week, which is a lot. So I see anywhere from 6 to 8 kids a day, not including travel time. So I drive to and from houses. I try to like group it between the 2 counties I work in. So I'm not driving too far. And those sessions are an hour. When I do the sessions at the clinic, they're only 45 minutes. So I see about 8 to 10 kids at the clinic, and then the rest of my hours are early intervention, where I'm seeing kids 0 to 3. In New Jersey, that's our provision. It finishes after 3. They can get services in preschool, and then some private clients. So yeah, I mean, a normal day for me, it doesn't really look the same every day, which is why I love it, and which is why I love early intervention. I really don't think I would ever go back to working for someone else. I love making my own schedule. It can be a lot some weeks. So like on some days I'm like, I can't, like, so the last like 2 clients I'll cancel, and then I can like see them on the weekends. Where if you work at a clinic, you can't really do that. And while I loved somewhere like Children's Specialized, their productivity expectations were crazy. So I got very burnt out very quickly. So this has been way more my vibe. I would say in general, there's a lot of unpaid work we do. That's probably one of the biggest negatives, I would say, about this like setting, I guess you could call it. We don't get paid for driving. We don't get paid for report writing. The only thing we really get paid for is if we go to like a transition meeting, if the child's transitioning into the schools. So we kind of do like the identification and IEP meeting, or like a 6-month review we get paid for. But, you know, I do all my own scheduling, emailing, making resources, talking to parents on the phone, yeah, there's a lot, but I love it. So I don't really get that upset about it. I would do this for free if I could. I say this all the time. And I have a quick little video that I thought was kind of funny. I just want to show you guys the back of my car as like an EI provider. I don't know if you can see it. Can you see my video?
I think you might have to switch share.
Oh, okay. Hold on.
And then actually, Nicole, when you do that, there's like 2 little check boxes at the bottom for sharing like computer audio. I think you'll need to click those too.
Okay, I'm going to do that really quick. Honestly, the audio is not that important. I just want to kind of show you guys what, like, you know. So yeah, so this is my back of my car as a traveling therapist. So there I have like 2 fine motor bins, fine motor. I have my like sensory tactile bin, books, water wows, baby toys, balls, my little block bin, puzzles, arts and crafts, and then some bilateral coordination type toys, and then some games. And then I have a nice little therapy peanut ball. So yeah, the funniest part about it is that early intervention is a bagless model. So a lot of times these toys just sit there, and I don't really put them in. But that's kind of like in general, if you work in early intervention, it's very common to have your car be kind of like a disaster zone, which mine is. So yeah, that's kind of what a normal day looks like. Oh, it did work, I guess. Oops. Okay. All right. So OT's role in neurodiversity affirming practice. I'm sure you guys know this, so I'll go over it really, really quickly. What is neurodiversity? Neurodiversity reflects the substantial diversity in human neurology. This was a term coined by Judy Singer, a sociologist who was autistic in the late 1990s. She kind of like spearheaded the ND affirming movement. So this includes so many different types of neurological differences: ADHD, autism, bipolar disorder, dyslexia, dyspraxia, lots of different things. Neurodivergent, that term was coined by, I don't have my notes with me, Casey Asimasu, I want to say, in 2013. And it was just kind of a more specific term to refer to a brain diverging from the norm. So to me, I think as a OT working in pediatrics, I think it's really important to know these terms, especially in the last couple of years. I think it's become a lot more like popular, I guess you could say. And I think helping caregivers understand what these terms mean, I think it can help them feel a little bit more positive about whatever the situation is and not think of their child as weird or bad or disordered, but just neurodivergent. And you'd be surprised how many parents themselves tell me, oh, I'm ADHD, or oh, I have a learning disability. And I'm like, cool, I'm ADHD too. Like, we're neurodivergent. So yeah, and then this is actually a graphic from PlaySpark, which is a fabulous clothing inclusive company. If you guys aren't aware of it, I highly recommend it. They sell the best t-shirts. I have like all of them. And I just thought this was a nice way to share what it means to be neurodiversity affirming. So we use a strengths-based approach. We try not to focus on deficits. We use the child's interest. We presume competence. This is really important, especially with our younger learners. A lot of parents and even therapists, I'm guilty of it, will talk about a child right in front of them because they are not speaking, but that does not mean they don't understand us. So that's really been a shift for me to be very mindful about how I'm speaking about my client in front of them or their parent. This is also a really important point when we talk about AAC and not limiting, let's say, a 2-year-old to something as high tech as an iPad because we think that they can't handle it. Excuse me, we respect bodily autonomy, so we try to not do hand over hand as much as possible or always ask for consent or gain some kind of nonverbal consent from our clients. Our focus is relationship centered. This is obviously super important in early intervention and working with the neurodivergent population and their caregivers. They need to trust us, and often family has such a huge impact on how their child is functioning. And then lastly, we value emotional regulation over compliance. A big hot button topic for the last few years around ABA, especially in the autism community. So moving away from that behaviorism model and moving more towards a relationship model. Okay, so when we talk about ND affirming practice, it's not, to me, it's not necessarily this like set guideline or, you know, formula that I follow. It's, to me and how I practice, it's meeting a child where they're at and recognizing their neurology and how it impacts their communication, their behavior, their skills, their learning, and trying to embrace the strengths and uniqueness that they have. Because we work so closely with families in pediatrics, I think OTs have such an important role in this and this kind of movement. We are often one of the first therapists in the door, especially in early intervention. A lot of times there'll be someone like what they call a DI, a developmental interventionist, or a developmental teacher. But a lot of times we're the first or second therapist in the door, and we kind of set the tone for how they look at their child. A lot of times it's like, you know, they're 2, they're not talking yet, they're doing all these weird behaviors. So I think it's a really awesome opportunity for us to come in and say, hey, this is why they might be doing this. And it's actually not weird. And this is how they learn. And this might be why they're communicating this way or not communicating. So I definitely think we play a big role in that with families. The other thing is our sphere of influence. Another really cool thing about OT is that there's so much gray, right? We do some of the same things as the PT, as a speech therapist. We work with teachers, we work with daycare staff, social workers. So we're often this kind of like central point where we can really have a lot of influence in how other professionals see neurodivergent kids. So one of the easiest ways is how we talk about our clients. And that kind of goes back to the strength-based approach. So instead of saying, you know, this kid is extremely attention seeking, you might say, oh, this kid really loves connection. He really wants to be connected to his caregivers. Or instead of, you know, they might say, oh, he never makes eye contact. He's constantly flapping his hands. You know, you can kind of point out maybe some of that like ableist language. I mean, there's been so many times where I've been like, ooh, can we not use the term red flags in front of like mom and dad? Or can we not focus so much on like joint attention and eye contact? And I think it's really helped to make more therapists aware, especially a lot of the PTs I work with, because I think a lot of OTs and speech therapists are kind of on this wave and PTs aren't quite there yet. And then advocacy, that's a big thing I do in both early intervention and private practice. I advocate for a lot of my clients in the school systems. I mean, COVID's really taken a toll on teachers and their capacities and their ability to kind of navigate kids and whatever issues they're coming in with. So really working with teachers and trying to be as helpful as possible and advocate for small changes or small things they can do in the classroom to help their student and make it be more inclusive. So yeah, so I think we play a really big role. Oh, and this graphic up here, just if I don't think I'll use much more of these terms, but neurotypical is if you have typical neurology. You can also be neurotypical and allistic, which is non-autistic. You can be neurodivergent and allistic. That would be like myself. I have ADHD, but I'm not autistic. I'm allistic. And then autistic fits in that little circle as well. This is another graphic I thought was really nice. Just some strength-based phrases that we can switch from. So instead of won't follow directions, we use, even I don't like self-directed, to be honest. I usually say like they're very like autonomous and they really like to figure things out on their own. Can't make friends. You would say they prefer independent play. Struggles with transitions, benefits from transition supports. Here are their deficits. Here are their strengths. And oops, sorry. And then they are obsessive. They have a lot of special interests and passions, which is really cool. Okay, so using a coaching model. Actually, I might pull up my notes for this. Give me 1 second. Oh, I don't think I'll be able to do it. Okay, that's fine. All right. So again, I'm sure you guys have learned about coaching at IC, but some of the main components of coaching include observation, action, reflection, feedback, and joint planning. So again, this was something I should have always been practicing a lot, but I think COVID really pushed that coaching model. And I actually took a coaching course because I was sitting and doing nothing. And I really went forward with it, and I still use it now that we're back in person. So I think a common thing for many OTs right out of school, and I still am guilty of doing it, is you just want to have the answers. You want to go in, you want to fix, or you want to be the superstar that tells the caregiver okay, try this and it'll work. But coaching is really not about that. Coaching is about empowering the caregiver and helping them feel confident that they actually have a lot of the answers, or they can figure things out, because once they can do that, they don't need you there all the time. We're only there for 1 hour a week, sometimes maybe 2. So if they have the confidence to support their child, it's game changing. So one of the first things I do at one of my first sessions is I do almost like an informal assessment of the caregiver and kind of the home. So I'll first assess kind of who they are as an individual. What's their tone like? How are they looking at me? Even what is the house like? That can tell you a lot about a person. And then I'll assess what their relationship is like with the child, and maybe other people in the house that are often there. I think this can really help your approach. Some parents are very enthusiastic and want a lot of like hands-on and ask a ton of questions. Other parents are extremely anxious. Other parents have been very aggressive. And, you know, there's only been probably 2 times where I've ever felt not safe, where I've had to leave a home. But for the most part, I know that if there's aggression or there's something, it's usually not about me. So I think that is a really important part of the kind of coaching process. Another thing I do is identifying where the family is at. Oftentimes the initial evaluation, if it's not done by you, the assessing therapist might write all these goals and the parents just like, sure, whatever you think, or like wherever you think they need to be milestone wise. And they don't have any like sense of like sometimes that they are supposed to be guiding the therapy or the plan of care. So I always ask them like, what is most important to you right now? Like, do you actually really want to work on toothbrushing? We totally can, but is this like super important? And you can also kind of get a vibe of where the family's at. You know, there's been plenty of families I've worked with where there's domestic violence going on, and they're trying to get away from the father, and there's legal stuff. They just moved or lost their job, or a parent is sick, or so there's always other things going on. So I think having a sense of that can help you know where your priorities should be too. I also really like to set expectations from the very start of the episode of care. This was a big mistake I made when I first started EI. I was nervous. I was coming into someone's home. It's a very vulnerable position to be in, and trying to like help their child. At that point, I was only 26, 27. I'm still pretty young. I don't have kids. So it's an awkward place to be. So what would happen is I ended up being a glorified babysitter because I did not set those expectations. So now the first session, I'm very clear about what therapy will look like, that we use a collaborative coaching model. I need them in the room on the floor with me, unless they have back problems. Like the whole session, I'm going to be asking them questions, and that's not to be annoying or test them, but it's really to figure out how we can work together to eliminate any barriers, adapt things, change things, work on a specific skill. And that's really helped because you'd be surprised how many times they come in and they're like, oh, you're not just going to like sit him in the high chair for 45 minutes like the other therapist does and I can go cook. I'm like, no, that's not what's going to happen. Another really important thing is creating trust and connection through a therapeutic alliance. It is not enough just to have a warm, welcoming energy and build rapport. Obviously that's important, but you really have, when you're working in this family-centered care, you really have to get to know the caregivers and respect where they're at in their journey. A lot of them have just received a diagnosis of autism, or maybe they're waiting to see if their child has ADHD or dyslexia or cerebral palsy, and it can be extremely emotional. So it's really important not to like push anything. Again, not only meeting the child where they're at, but meeting the family where they're at. And this is going to be really helpful in creating that alliance. I also think being on the family side, I think when I worked in schools, I felt like it was a little political and I was on the school side, where here I'm like, I'm your number one advocate. Like, obviously I work with a speech therapist and the PT and I want to be a team, but like you and your child are always my number one. And that can be hard because they'll talk to me about how they don't like the speech therapist or it's not a good fit. And part of me feels bad because I don't want to throw a fellow professional under the bus, but I tell them like, listen, if it's not a good fit and they're not serving you the way you want, ask for a new therapist. Another thing with coaching that I do is I ask questions. I do a lot of wondering. I like to reflect and be creative. So a big shift for me again was we learn all these amazing strategies, treatment approaches in school. But if you go in there and say, okay, I want you to try this, it's kind of like, whoa. So one thing that's really helped me is asking a lot of questions. So let's say they want the child to put on their coat by themselves because it's such a rush in the morning and it just would be so helpful. Okay, awesome. What have you tried? What kind of coat are they wearing? What's going on in the background? Just asking all these questions, and it can really help you figure out what strategies they've already tried, and what hasn't worked. So you're not telling them something they've already tried. Let's say there's a child who has like attentional issues, and the house is just a tornado. And it'd be very easy to go in there and say, clean up all the toys. Let's have a very clear environment. I might say like, I wonder what kind of things might be impacting his attention. If they don't come up with the answer, I might say like, here's an idea. Like, I wonder what would happen if we did the therapy session in your room, like on the bed. Like, let's just try. And reflect, okay, why did that go well? Or like, why did that go terribly? Like, why do you think they had like a meltdown? So, it's about that like give and take and really trying to help the parent feel empowered. Another thing I try to do is use a lot of leveling statements. So, saying something like, wow, like I can see how many things you've already tried. Like you're very intuitive and creative, or like, he's really lucky that he has you. Like I can see how mindful you are about his sensory sensitivities when you're in the community. So making statements like that can really help caregivers feel confident and like they're on the right track. I also say a lot of times, I don't know. And I think that can be really helpful. If I get texts all the time from very anxious parents, mostly of my older kids, and they're like, they had this huge meltdown and they started hitting me and this is what I said. I don't know why. And I'm like, oh, that was such a good response. And like, I don't really know either. This is so tricky. Like, let me have a think and get back to you. And I think that can be really helpful too, because when you're coming into a home, whether it's early intervention, private practice in the home, or even in a clinic, a caregiver is in a very vulnerable position. You're seeing their house, you're seeing them have difficulty with their child. So just being able to say like, hey, sometimes like, I don't know either, and this is really hard, can be really helpful. The last thing is being realistic, which is actually something that I probably only started doing in the last year, meaning let's say we do come up with some kind of strategies after we ask questions and wonderings and whatever. I've started asking, do you think this would actually be helpful, or would this be too hard within the context of your routine? Is this actually realistic? And I've gotten a lot of like, you know what? No, like we just can't right now. Like I know a visual schedule would be so helpful, but like, I just can't right now. And I'm like, that's totally fine. We'll revisit when you're ready. So being realistic and asking those questions, because many of our neurodivergent kids have neurodivergent caregivers, whether they're diagnosed or not. So executive functioning, time management, all of those things can be very difficult. So being realistic about the strategies, even if it's a great one you came up with together, is it too hard right now? Can we do this? So yeah. In conclusion, early intervention and private therapy in settings like a sensory clinic or home have been my favorite place to work in pediatrics. I really don't think I'm ever going to go back to anything else. You can really make therapy your own. You don't really have a supervisor hanging over your shoulder, worrying about productivity, or, I personally don't like ABA, so I don't have anyone pushing behaviorism on me. We make lasting connections with families, and we can really set the tone for how a caregiver embraces and celebrates their neurodivergent and disabled child. These are just two little graphics that I actually made from my professional Instagram, which I'll show you in a second. So some of the pros for working in early intervention: very flexible schedule. There's relatively a lot less paperwork than other pediatric positions, which is a huge plus. You get a much higher hourly rate. I've been able to negotiate pay raises like 4 times in the last couple of years. You get autonomy with your therapeutic approach and you make close connections with families. Some cons, there's no paid time off or sick leave for most agencies you work for. If you're an independent contractor, it can be different in different states. I know like California does pay for some like documentation time and travel time. New Jersey, you don't. There is a lot of time spent traveling. So if you don't like driving, not the best. I still get no-shows and last-minute cancellations, which can be very frustrating because you don't get paid. You can show up at the door, and if they're not there, you're not getting paid. There can be some occasional discomfort in working conditions, so dirty homes. I've worked along cockroaches and feces and other things. A lot of times you can be a glorified babysitter. I've had families fighting in sessions. So yeah, there can be some discomfort, but overall, I really do like it. Here are the few resources I used, and then where you can find me. So you can follow me on Instagram. I am the Blonde OT on Instagram. That's my professional page. And then you can always email me at nicolereadiot@gmail.com. As I said, I work in central northern New Jersey. The clinic I work at is called Sensational Therapies. If you have any family members or friends who live in New Jersey who are looking for a clinic, I think it's pretty great. I also just got my level A DMI certification. So I'm hoping to get my level B by this spring, and I'm going to be starting to do therapy intensives for more neurologically involved kids by the fall and winter. So that'll be really exciting, a little bit different than some of what I'm doing right now. But yeah, I think that's it.
Okay, thank you so much, Nicole. That was a really informational presentation.
No problem. So I look at the chat. Yes, NHS is the National Healthcare Service. Yes, so it's very different than our healthcare system here. I actually came to IC a couple of years ago, and I did an in-person presentation about working as an OT abroad. So I could always share that info if you guys don't have it still. So yeah, any specific questions or just things in general you want to know about pediatrics, or even like just coming out of IC as a new therapist?
I do have a question. So, just a little bit of background, like I just graduated in December and I just passed my board exam. But
Congrats.
thanks.
Yay.
So I was just wondering, what I noticed a lot in my specialty field work was that a part of it was I was in a feeding disorders clinic, and we followed a similar coaching model with our patients and our clients, and a lot of them also had I had a lot of neurodiverse clients as well, a part of it. But a lot of times the parents would ask me, why is like this different than ABA, or like talk about like the comparisons between the two. But how do you go about like discussing parents OT versus like following ABA?
That's a great question because it does come up a lot. So there was some other stuff I wanted to talk about in the presentation, but I didn't want it to go too long. So I try to always give parents the other view of ABA, especially in New Jersey. We have one of the highest incidences of autism in the country. So what happens is a child gets diagnosed. A lot of times, I mean, I just had a 16-month-old get diagnosed that I'm seeing, but a lot of times it's at like 2.5. So they go get diagnosed. The developmental pediatrician says, your child is autistic. They're going to need all these therapies. They're going to need OT, speech, at least 20 hours of ABA if you want your kid to like be normal, more or less. It's terrible. So I have like an email that I have, and if the parent's ready for it, I will send them resources. And a lot of these resources come from actually autistic people. They're way more strength-based. And then I have some information about ABA. This is not to push my agenda. It's more to give them, again, a holistic view, because if you type in autism ABA in Google, it's the gold standard of therapy for autism. It's all positive. And I think it's a really huge disservice that these doctors are doing for these families, because they're not giving them the whole picture. So I've had this conversation with families multiple times, trying to keep it as like kind of neutral and professional as possible. I've had some families still go ahead with it, and some families be like, I'm never doing this. I think there's a lot of crossover that I'm seeing for ABA. They're working on toileting, they're working on dressing, and they do not have a background in neuroscience and child development and sensory processing, which we know affects all of these things. So I've been in very uncomfortable situations before where I've had, a client who's 2 and they have 16 hours of ABA a week. And usually the RBTs are fine. Like usually they're very pleasant. It's the BCBAs, which typically don't love us. And, I've gone to that. And at the end of the day, like I said, like, I'm not scared of offending them. Like my loyalty is with the family. I'll always keep it professional, but I have pretty frank conversations about ABA. And I try to explain where they're coming from more of a behavior model, or at least I'm coming from more of a relationship-based model where they actually are developmentally, and always prioritizing the feelings of safety and trust, which I definitely feel like gets skipped over a lot using a behavioral approach. So yes, RBT is registered behavior technician. So the BCBA, the board certified behavioral analysis, they went and got their master's. They're the ones who create the program for the child, and then often they will oversee it, but the RBT is the one who actually carries it out. A lot of times, again, they're lovely people and they usually love kids and they want to do the best. A lot of times they don't have a college education. They take I think it's a 40-hour course online.
Oh, so I always thought it was, I'm sorry, I misunderstood you before.
No, go
But
ahead.
I always thought it was like an OT and an OTA, but an RBT is not anywhere even near close to an OTA. Oh,
No, sometimes they
not-
can be, but many times they are not. And
I'm sorry.
no, that's okay. I mean, I didn't even know this again until a few years ago when a parent went and took the course to technically be an RBT, because she's like, I want to know. So, again, I think a big thing of this is keeping in mind cultural, racial, socioeconomic differences. I work in some not so nice parts of New Jersey, and parents are scared when their Black little boys are seen as badly behaved, and a lot of them don't have the resources to get childcare, or they're just I just had this happen the other week where the mom was in tears to me because she didn't want to put him in an ABA program, but she's like, I'm so depressed, I'm so anxious, I don't know what to do, because she's a baby, so she can't leave, and I'm like, listen, do what you got to do, tell them what you want out of it or what you don't want used, and it's okay. You're not. So, you have to be very conscious too about putting out your opinion, because we don't know what it's like. Most of us don't know what it's like to have a child in that position or be in that, socioeconomic situation where they need to work and daycares won't accept their kids. So what do you do? So it can be hard.
Yeah, thank
Sorry,
you.
hopefully that answered your question.
Yeah, that was so insightful. Thank you so much. That actually was really nice. Thank you.
Anyone else? I don't know if any of you are interested in pediatrics.
Yeah. Hi. First of all, thank you so much for being here.
Yeah, of course.
And also the fact that you work in sensational therapies. I've literally had their page bookmarked on my Google for a year and a half because I live in the area as well. So
oh my gosh, where do you live?
I'm from Hunterdon County. I'm 10 minutes away from Clinton.
Oh, cool. Okay,
Yeah.
nice.
So
Yeah, so it's just in case there's multiple, it's sensational therapies in we're in Short Hills, New Jersey.
yeah.
Okay, cool.
But sorry, that's not my question, just fun little
No, that's
connection there.
okay.
But this was actually, I was so excited for this topic, but it's coming at a really good time because I'm on my second day of a level 2 at a school. And this is going to come out sort of rambly, like not fully a
No,
question,
go for
but
it. I'm often
one
rambly.
of my one of my supervisors, I've only had one day with her so far, so I'm trying to like withhold judgments and stuff, but just on my first day I'll say it was very much a reminder that I'm not in the Ithaca bubble anymore in the things she was saying and how she was saying it. And I did not get like a strengths-based neurodivergent embracing vibe from her. And so I know sort of like interpersonally, like I was already trying to respectfully like push back a little bit of what she was saying, but the school district I'm in does heavily use behavioral therapies and BCBAs. And like not to make this whole conversation about that because the work you're doing is amazing. And I don't want it to only be about behavioral therapy, but I'm just wondering if you
that's
have
okay.
any advice, like if I don't necessarily want to refer a kid for more behavioral therapy, but like the scope of OT practice in the school district versus behavioral is already pretty set. Like, do you have any ideas on how to navigate that, especially if your supervisor isn't like the most?
Yeah.
Yeah.
Yeah, I mean, that sounds really hard. I remember one of my level 2 field works. I mean, I would like come home crying like every day because it was really hard. So, you got to pass your field work. So don't like go in there and be like, well, I think this and you're wrong. But that doesn't mean that you can't still like use your own style and like ask questions. Sometimes even like coming in being like, oh my gosh, like I took this really interesting course and it was all about like XYZ. Like, I wonder how we could like, put it on like your learning or something. Like, I wonder how I could apply this. Or there's a really great, I don't know if you know him, there's a really great school-based OT and he's very big into behavior. His name is Greg Santucci. He's an OT. But he has some really great ideas and resources for pushing back against behaviorism in school. If I'm being 100% honest, this is why I did not like being in school, because I felt very out of control of how, like, not even how I treated, but like, I don't know. It wasn't my vibe. I hated the IEP goals I was getting. It was really hard. But I think again, asking a lot of questions, not in like a snarky way, but really like a true curious way. And then maybe like bringing some of your own like research or things that you find. I mean, I think a big thing now too is supporting kids with AAC options and using a different approach with communication for autistic kids. Because I just took this course recently, but we know that most autistic kids are Gestalt language processors. So they process language in a different way. And I think that's a big new thing. And, a lot of what we've been doing is wrong. So, I think again, just like coming from not like I know more than you, or because I don't think that'll go over well, but just, yeah, trying your best to like ask questions it's really hard. Oh,
That's super helpful. Thank you so much.
Emily?
Yeah, I just wanted to say something to Emma. For my in-service, for my school level 2s, I actually did a presentation on how like OTs can help it not address quote unquote challenging behaviors, but how we can help interplay with that, and also how OTs and like behaviorists are different, but also like try to like even out the playing field of like how we can relate with one another and work together in a more like what's it called? Like just work together in a more productive way rather than as like
separate
dollars.
entities.
Yeah, like separate entities, how to work together. So that could be something I can send to you. But also I do have another question. So I do have a very important interview with a PEDS outpatient clinic. So I was just wondering if you have any tips or suggestions of going about that interview.
Oh my goodness, how exciting. I would say, they always say like have some questions to ask wherever you're interviewing. So like, what is your typical day look like? Where do you see this clinic in 5 years? What type of like continuing ed learning opportunities? Is there a specific model you use? One thing that I thought was actually a really great way when I was interviewing for my job in London, they had me present on a case study. I was like, oh my God. But it was actually a great way to kind of show who you are as a therapist and them to get your understanding. So even though they might not ask that, that might just be like a good thing to even like put together yourself, because then you can like go back to that. And if they ask you a question like, what's one time you had a difficult situation with a parent, like how did you navigate that, or how did you navigate a conflict with a colleague or something like that, that could be like a nice thing that you have in the back of your mind. It was very different interviewing in London because it's all a point system. So I had actually interviewed for a different job in Scotland and I lost to a girl by 1 point and I wanted to like die. It's not subjective, it's objective. But anyway, I'm sure you'll be great. Just prepare, try not to like get too nervous, do all your like regulating strategies before the interview and you'll be good. You'll get it.
Thank you.
I have a question for you, Nicole.
Sure.
I have a lot of thoughts as you were going through that, mostly where have you been all my life? It was so amazing to hear your insights. What a hopeful, just, story that you have to share. And you make me feel really hopeful about our profession. A lot of times there tends to be like lip service type of a thing. Like, yes, we know what we're supposed to say and we know the PC thing to say and do, but like to see and hear about like folks actually doing it in practice is really, really amazing. Also, I have all these ideas going on in my head about like, you need to get in touch with one of our thesis student or one of our grad students, Stephanie Fine, who, just 2 days ago, right? What's today? Wednesday, 2 days ago, presented on, clearly you're on social media. Do you know TJ Joseph, nigh functioning autism?
Yes, you do.
So TJ was our co-researcher, was Stephanie's co-researcher on her thesis.
Amazing.
Yeah.
That's so cool.
And so many of the things that you're saying, right? Like hashtag actually autistic folks, like centering that, like thinking about intersectionality and how a Black autistic kiddo is going to need to mask for safety in some cases, right? Depending, all of these things are so, so important. And clearly coming from you as an ND OT, right, is just adds to the beauty and layer and ability to meet the needs of your clients. It's really, really a tremendous thing. So yeah, I would love to get you in touch with Stephanie.
Yeah.
I don't know, like based on her research and your work, I see like this bigger, I don't know, presentation or collaboration. I'm an ND OT as well, and really interested. I do disability studies work and working on an AOTA position or an AOTA continuing ed article with an autistic activist also to try to think about reframing some of the things that we do in OT. And yeah, just such a real need to have OTs on the ground working, doing ND affirming care, which is clearly what you're doing. So thank you. I actually do have a question.
Sure.
And I have a couple of questions, but for sake of time, I'll just ask the one silly one is, so one, I saw that you were wearing in one of your photos, a 3E Love sweatshirt with a wheelchair heart. And right, again, from a disabled entrepreneur.
I actually got that when I was at IC. Yeah, we had like a fundraiser. Yeah, so I still wear it.
Yeah, no, Stevie's a friend of mine out in Chicago. Yeah. And but I want to know you said there was another brand that And is that the
It's-
shirt you were wearing at the end? Because that was amazing.
Yes, it's called Play Spark. I just wrote it. Their quality is amazing. I've ordered a lot from like Etsy, and I found that like, because that's my uniform, I wear like a t-shirt and scrub pants. So I wash a lot. And I found like the graphics kind of start to peel, but Play Spark has really good quality and they have really fun stickers. They just came out with a new, like 3 new designs for the spring. I really need to stop buying them, but I can't. So yeah, so definitely there. Great Lakes OTs is also a good one, but again, like doesn't always stay great. So yeah, I recommend Play Spark totally.
Yeah, just thank you for your work and for doing
Yeah,
this and for sharing it back. And we would love to have you again in the OT department, if I can
I
say.
would love that. And Shari asked a question. Sherry, I'm sorry if I'm saying her name incorrectly. How do you approach a situation where the parent wants their child to be neurotypical? I would say just, you got to give them grace. You got to meet the parent where they're at. You can't force a parent to accept their kid. I mean, it can be really frustrating and it can be really hard, but I guess what I try to do is just like point out all the strengths that I see. And if there are differences or support needs, not highlighting those, but like also talking about how we want them to be successful in school, in their social relationships. So we also shouldn't be pushing things that are uncomfortable or unnatural for them. And I think, again, like if you're interested in this type of OT work, I really think we need a lot more OTs in early intervention, because this is where we set the stage. I mean, you can really change a course of a child and family's life when you have the right therapy and the right outlook. So yeah, I mean, I have interest in other areas, but I really don't think I'll ever stop unless my back gives out, because it's really not great. But until my back gives out, I will be sitting on those floors in early intervention. I love it. The kids are amazing. The families are amazing. Especially if you're in the tri-state area, if you hang around here, there's a lot of autism, but I've just really seen a huge shift over the last couple of years, and it's really exciting. But there's still just like a lot of deficit-based approaches and people who are stuck in their ways. So I think, if you want to make change, like this is where you can do it in one way. I know there's other ways, but this is a pretty direct way. So yeah. Okay, does anyone have any other questions, or do you guys want to wrap up? I'm not really in a rush, so I could talk about this all day. All right, well, if not, please feel free to follow me on Instagram and write down my email. I'd love to talk more to you, Emma. I don't know how many other fieldworks you have, but I could always talk to our clinic director, Jody, if you need to do like your level 3, or I could even take you on if you want. So yeah, just let me know. And thank you to Lauren and Aksa for moderating, Mindy and Jenna. This was so great. So nice.
I want to say thank you again just for presenting and being able to come. It was really nice to have you and really nice to be able to hear everything. And obviously the Q&A was really informative too. So thank you. This is just a reminder for everyone that the video and the transcript will be provided on YouTube. And our next speaker series is Grace Ambrose on April 19th on accessibility specialist for Lululemon. So yeah.
Cool. All right. Have a great rest of your week, guys.
Thank you
And
so
Thank you,
much.
everyone.
congrats on passing boards, graduating, all the things.